see we have participants from Ghana, from Zambia, from the Netherlands, Ethiopia, Germany, Channel Islands, the United Kingdom, South Africa, Kuwait, Vietnam. It's really great to see the global representation of people on this webinar. Really very pleased to have you with us. So we will start, and I'd like to say a warm welcome and good morning, good afternoon, and good evening to everyone. And we're very happy to have you with us for this third WHO EPI-WIN webinar in the Science Translation series. My name is Ramona Ludov, and I'm a Technical Officer for Evidence-Informed Policies here at WHO headquarters in Geneva. It is a pleasure to have you with us today for this webinar that will focus on using local songs and storytelling to engage remote communities with health messages. The COVID-19 pandemic is affecting really everyone and everywhere on this planet. So knowing how to engage in protective actions is essential to stop the spread of the virus. And while such measures stem from research and are mostly implemented through policies, it is really ultimately the communities, the families, the households, the individuals who determine the success of such measures through the consistent uptake and adherence. So the engaging in public health and social measures is often a key defense strategy against infectious diseases, especially in remote communities and areas where people do not have easy access to healthcare services. But then the question is, how do you translate the latest evidence on how to protect yourself, your family, and your community from COVID-19 so that it actually becomes relevant and understandable to the people you want to reach? And fulfilling this promise to leave no one behind requires really innovation and creative thinking here. This does not always mean in terms of innovation that you use the latest technology. Sometimes innovation and creativity really means going back to our roots and applying communication forms like singing and storytelling that have been used over centuries to pass on information. I'm very happy to introduce you to today's speakers who are true champions in translating science into effective and tailored messages to make sure that everyone, no matter where they live or what scientific background knowledge they have, can protect themselves against infectious diseases such as COVID-19. So we will hear from Rinja Ganai-Bosson and Nadine Müller from the NGO Doctors for Madagascar, and Patrick O'Quinn, who's a team lead at Effective Basic Services Africa. We will have two presentations that will then be followed by a moderated discussion. So please feel free to submit your questions to the speakers throughout the presentation. I will compile them, and in the end, they will be happy to answer them for you. So you can submit your question through the Zoom Q&A function, and we kindly ask you to use this function as it's a bit easier to compile the questions than to have this through the chat. I'm also very, very pleased to tell you that we do have a simultaneous interpretation in French available for this webinar. So please just switch to the Zoom interpretation channel in French to then listen to the interpretation. There will also be a recording of today's session that we will publish on the WHO website and the WHO EPI-WIN YouTube channel. And with this, I'm handing over to Rinja and Nadine to talk to us about their experience with conducting singing sensitization in remote areas in Madagascar. Rinja and Nadine, it's a pleasure to have you with us. Over to you.
Hello, everyone. Do you hear me?
Yes, we can hear you.
Okay. Good afternoon, everyone. So my name is Linda. I'm a project coordinator at Doctors Madagascar, an NGO that is active in the southwestern part of Madagascar. So right now I'm in Ezeda. It is a small village that belongs to Ampani district in the southwestern region of Madagascar. So I'm really talking now from the field. And thank you for inviting me and my colleague Nadine to be part of this webinar, which means a lot to me. And thank you as well for giving us the opportunity to share with all of you our experiences from the field. The topic here is all about communicating health messages in the rural south of Madagascar. But before sharing with all of you our experiences from the field about this topic, I would like to make you familiar with the context by talking about my country just in general. So Madagascar is a low-income country located in the Indian Ocean in the southeastern part of Africa, which has a population of 28 million. The majority of the population live in extreme poverty, and most of them, around 80%, are subsistence farmers and live in the rural areas. The maternal mortality rate is still very high, 335 over 100,000 in 2017. All world diseases still exist time to time, like leprosy and plague. But let us focus more on the southern part of the country where our NGO is more active. In the south of Madagascar, there are 4 regions, which are Asimandefana, Andrui, Anosi, and Menabe. The highest rate of poverty is found here in the south of Madagascar. The healthcare system is weak, lack of healthcare facilities, specialist physicians like surgeon, equipment, drugs, qualified health workers. Roads are in bad conditions. Only 4x4 and big trucks are able to use them. During the rainy season, some parts of the region are fully inaccessible. Due to climate change, drought is affecting the region. Therefore, people are decreasingly able to cultivate and harvest. In result, hunger and starvation is hitting severely the population. Illiteracy rate is very high as well. Unfortunately, data on illiteracy for the south are missing, but in general, in rural Malagasy areas, less than half of the people can read or write. There are different ethnics and tribes with their own dialects. So what are the main key challenges for health communication in the rural south of Madagascar? Rural villages are very hard to reach because of bad conditions of the roads. Many people are not educated, and it is hard to make them understand our messages and provide them with a sound basis for informed decision making. There is a wide language variety, which makes it difficult to transmit messages. For instance, someone from the capital cannot just come here and sensitize people in the south because he won't be able to communicate in the local dialect. Malagasy newspapers and radio broadcasts don't reach the area. There are many places where there is no network, so the use of telephone and internet is still very low. Traditional cultures and beliefs are still very strong, which needs to be taken into consideration when designing communication strategies. So facing these challenges, Doctors from Madagascar, registered charity based in Germany and Madagascar, has been active here in Madagascar since 2011. It has more than 90 staff now. We are working with more than 70 public and private health facilities, and we are focusing on 4 main areas, which are maternal and child health, infectious disease like tuberculosis, financial risk protection, and quality of care. So our main goal is to improve the quality of care and the access to essential health services for vulnerable populations. So in order to reach this goal, one of our main and key activities is improving health education by community sensitizations. So we put in practice 4 types of sensitization. The first one is what we call household visits. The second one is focused discussions. The third one is mass sensitization. And the fourth one is singing sensitization. All these different types of sensitization follow the same strategy. They aim to improve the knowledge, change attitudes, and correct misconceptions. So let's talk about the household visit first. In French, we call it visite à domicile. We work with local community health workers. So they'll go to these remote villages and visit each household. During the visit, they will be using tools like picture boxes to transmit key health messages to the family in the household. They will do their best to inform them so that these people can make the right decision. After finishing with one house, they will do the same with several houses in the village. Individuals are selected based on a specific risk, like for example, pregnancy. The second type of sensitization is focused discussion. At remote villages or at the health center, we gather like 7 to 10 people maximum with the same criteria. For example, 10 pregnant women or 10 delivered women. Then we choose one or two topics, for example, prenatal care or vaccination, and we lead the discussion about these topics. The participants are free to share their opinions and ask their questions. The discussion is active, but always ending up with the transmission of the main key messages by the leader. The third type of sensitization is what we call mass sensitization. So this is basically transmitting health information at highly frequented places like the market, where many people are present. So what we do is that we stand at one place and we start to sensitize people using megaphones, sound boxes, and music. So out of this mass sensitization, we found out a new way, a new technique to transmit key health messages, and that is singing. So talking about singing sensitization, which is the fourth one, we found a local singer during the severe measles outbreak in Madagascar in 2019. Inspired by the existing situation, the singer wrote a song about it, talking about the symptoms, its transmission route, the vaccinations. So when we listened to the song in public, we realized that it was so good and people were so listening and so amazed about the content. For example, he said, when children have fever, take them to the hospital. Or also, take the children to the hospital for vaccination because it's the only way to fight against measles. So from that moment, we had this idea of having this singer with us during our mass sensitization, helping us sensitizing health messages through his songs. Then we asked him to write songs about maternal health because, as we know, the maternal mortality rate in the region are still very high. Also, we asked him to write a COVID song during the outbreak in Madagascar in April 2020. And also, we asked him to write a song about tuberculosis, a common but neglected disease in the south of Madagascar. So basically, we give him the main messages of these topics, and he puts them in the lyrics. After the songs are done, we check again the content before we start to sing it in public. So what are the advantages of singing during the sensitization? It is first about sensitizing the population through songs. All key health messages are included in the lyrics of the song in the local dialect, which makes it easier to understand. Singing is a very good way to attract people's attention so that more ears are open to listen to the messages. At the same time, people are feeling entertained and happy about it. They really pay attention. So in conclusion, what are the key learning and recommendations? First, closely work together with the community leaders. Be aware of the fact that differing messages might create mistrust and hesitancy among vulnerable, hard to reach populations. Team members that come directly out of these communities can be strong facilitators. Be present and reachable for your partners and communities to enhance trust and acceptance. So this leads me to the end of my presentation. I hope you liked it, and thank you everyone for listening. If you have any questions, we are very happy to answer them. Thank you.
Thank you so much, Rinja. That was truly interesting, and I especially enjoyed all the photos that illustrated the work that you're doing in Madagascar. I'd like to give the chance to Nadine to add anything or, just contribute also to the presentation before we move on to the next one. So Nadine, if you'd like to add, please feel free to take the floor.
Well, yes, thank you very much. So my name is Nadim. Hello, I'm also part of the NGO Doctors for Madagascar, working together remotely with Rinja on different projects and activities. And fairly said, it's Rinja who is like the head of the sensitization activities. So he's really the best one to talk about this topic. And we are really looking forward to your questions later on in the Q&A session. Thank you.
Thanks so much, Nadine. Yes, this is also a timely reminder for everyone. So if you have any questions to Rinja and Nadine on the Singing Sensitization project, please submit them through the Q&A function in Zoom, and then we'll compile them and try to answer all of them during the discussion. And so with this, I'm very happy to hand over to Patrick, who will talk to us about the eBay's initiative Evidence Story Day, which means let's talk evidence in local pidgin language that is spoken across Middle Africa. And we're very happy to hear from you. And I'll try share your slides. So please do let me know if that works.
Yes, that's loading. Okay. Hello, everyone. My name is Patrick Okwen. My name is Patrick Okwen, and I'm a medical doctor by training, health economist, and I'm the team lead at eBay's Africa, where we work with traditional storytellers to get research evidence into practice. And this is in essence, okay, if you can remove the turn on, okay, good, it's working. Okay, so in essence, we work with traditional storytellers to get research evidence into practice, because as you know, sometimes guidelines from doctors are based on research evidence of what works. But sometimes getting these to convincing the patients to take up new interventions, new health technologies is a challenge. So I'll share with you today our experiences in that light. So I'll start by this song we used to sing in childhood, and it used to go by the word storytelling is part of our culture. We must always use this to teach our children the skills they need in life. This was a school song in Cameroon. We used to sing this a lot when we were kids, but right now I think my voice is very bad. I wouldn't want to bore you with my voice. Slide, please. So the background of Cameroon, the context of Cameroon is quite similar to Madagascar, which Rinja has presented. But there's also a strong evidence policy practice gap, which is characterized by the complexity of research evidence terminologies. For whom, by whom is research evidence made available, and in what form are questions that we need to be asking ourselves. When we disseminate research evidence with odds ratios, risk ratios, confidence intervals, I-square, heterogeneity scores, many people will not understand, not even just the non-literate people. So to bridge the evidence gap in Africa, inclusive African-led approaches should be explored. For example, storytelling, which is part of our culture. We also admit that 72% of the world's non-literate population is in Africa, thereby making the need even more. Slide, please. So the African traditional storytelling serves as a way of passing on traditions, codes of behavior, as well as educating and maintaining social order. And we see that from this, storytelling can communicate information and messages in a non-confrontational approach. It can also communicate this to citizens who are not science savvy. It can communicate this to low literate, non-literate, and people living in remote communities. And as we can see, this is in essence something that could be beneficial, not just to the low literate communities, but even in high income countries in the north, where messages need to be communicated in non-confrontational approaches, especially in a season of COVID, like where we are now. Communicating messages to people who are not scientists, you need to do it in a way that's non-confrontational. So this approach can be used for science communication and can be relevant beyond the low and middle income country settings. Slide, please. Now, where did we start? How did we get here? In the beginning, in 2010, 2014, we were struggling to get guidelines for doctors to use guidelines for treating uncomplicated malaria. And these were guidelines that were developed by WHO for African countries globally for the treatment of uncomplicated malaria. However, the doctors were taking up these interventions. And the first one that we did here, you see, was artemisinin-based combination therapy for uncomplicated malaria management amongst children under 5 in Cameroon, which we published with the JBI evidence synthesis. And the uptake was very good on the part of the doctors. Slide, please. However, there was still a challenge with this approach. So we tried another approach, which you can find on ebmafrica.net, where we actually got the WHO guidelines and the nationally ratified guidelines from WHO and the foreign guidelines on the same topic onto this website, where clinicians could actually access and use. Slide, please. We also did some publications even on malaria, still using WHO guidelines and other guidelines with Magic app, and which we published in the British Medical Journal. However, there was still a missing link. The doctors were happy to use the evidence, but when the doctors tell the patients that for us to provide you with malaria treatment, we first need to do a test. And if they diagnosed uncomplicated malaria, they would tell the patients that all you need is an oral medication. But the patients were not understanding why they had to do a test instead of just treating them the way they used to treat them in the past. Or why do they have to give them tablets instead of giving them injections that they have been giving them in the past? So we found out that there was a divide. Slide, please. So meanwhile, we were spending time training the doctors. There was evidence uptake hesitancy coming up from the patients. And we also noticed from Rinja's presentation that he also spoke about this same hesitancy to take up health interventions that were effective. This was especially because there was an asymmetry of knowledge. Meanwhile, the doctors have been updated with new health technologies for the treatment of malaria. The patients were not informed. So there was still that hesitancy for them to take up that evidence. And then with COVID-19, this even became more complicated. There was disinformation, there was misinformation, there was distrust. So it was even more difficult for a healthcare worker to tell a patient that you are positive with COVID and you will need to be quarantined or treated in the hospital. In Cameroon, there were several cases of doctors who were beaten up because they made positive diagnosis of COVID. So many doctors, once they see a COVID case, they found a way to just send them back home for fear of their lives. So along the line, we had also tested, run some qualitative studies to understand why patients are hesitant to take up evidence. And the figure on our right-hand side tells us exactly some of the reasons. Sometimes it's because consumers doubt the evidence. Sometimes the evidence is not useful if it's not affordable. If you tell someone that you have to do a test, but they cannot pay for the test. They'll just tell you that we are not interested. Sometimes the patient wants to do things the way it had been done in the past. Sometimes they make statements like they already know. So these were some of the reasons that we saw for the evidence hesitancy. Slide, please. Now, so we now came on to start thinking about storytelling, and especially in COVID-19, we knew that this was really, really important because we were competing with misinformation or misinfodemics. And we felt like this was being taken for granted. And we started asking ourselves questions like, how inclusive was the fight against misinformation? Meanwhile, the people who are disseminating misinformation are using all sorts of approaches. They're using audios, they're using posters, they're using pictures, social media. Research is not using the same. Slide, please. Now, let's look a little bit at how much stories and science we have been dealing with since we started this project. I would like to highlight that we started this project, developing these projects around 2016 and without any funding. And since then, we've been trying to get scientists and storytellers together and tell stories across Cameroon around malaria, COVID-19, sexual and gender-based violence, and menstrual hygiene management. And our approach has always been to run the storytelling events in cities for a price. So participants have to pay, and then we collect the money and we are able to pay artists to also go and tell the stories in remote areas, thereby keeping ourselves going. Slide, please. Now, since then, for COVID-19, we developed 3 stories, and we've told these stories to 5 communities with over 3,000 citizens. There has been no COVID-specific funding as well, and funding could actually help us to have more focus and more evaluation on how this approach is actually impacting on communities in remote context. Slide, please. Now, since 2016, since the inception, we've told these stories to over 50,000 people across Cameroon, in rural areas especially, but also in urban areas. Slide, please. So now, I want us to look at why do we even tell science stories in the first place? In the pictures you can see on the left-hand side, there's a scientist working in the laboratory. So scientists could work in the laboratory for 3 years, trying to come up with research evidence of what works. Meanwhile, the conspiracy theorist will wake up in the morning at 5 a.m., sit on his toilet seat and just craft a conspiracy theory, and boom, it goes on social media. And then he now can compete with the scientist who has been working for up to 3 years. Next slide. So if we look at this, I want to give an example of how the scientist who has been working for 3 years reports his results. He says that the effectiveness of full messenger RNA, mRNA vaccination more than 14 days after the second dose was 89%, 95% confidence interval, etc., etc. Slide, please. And on the next slide, we see what the person sitting on his toilet seat will do in a few minutes. He says, I'm sure some of you may know the lyrics of this song. It's a very popular artist, the Rolling Stone, the guy who is the lead guitarist at the Rolling Stone, who wrote this song, which was serious misinformation against COVID vaccination. And he just goes, I knew that something was going on wrong when you started laying down the law. I can't move my hands. I break out in sweat. I want to cry. Can't move it anymore. So next slide, please. The question here is, if you were watching this tool, who will you go for most? So I leave this for you to judge. Now, how do we tell stories? We tell stories by engaging the community members. That's where we start from. And then we take a rigorous and systematic process at synthesizing all the evidence around the topic that we want to tell. And then we collaborate with storytellers. And then we evaluate how behavior is changing. And then we give feedback to the storytellers to develop more stories and come back to tell to that community. Slide, please. Now, let's look a little bit at how we engage communities. First of all, we identify a hot topic. For example, the hot topic in Cameroon for COVID was COVID-19 at that time, earlier this year when we started the fight against misinformation in COVID-19. So COVID-19 was a hot topic. There were lots of stories around it. Some people were saying that it was just the government coming up with the reason to get money from donors. Some people were saying that it doesn't affect Africans. So there were so many false information going out. It could also be where that a decision maker proposes to us that I want you to tell a story around this. For example, WHO could say, okay, or the ministry could say that we want you to tell people that it's important for them to wash their hands or wear masks in public places. Or there may be a community issue like gender-based violence. A little kid is raped and the community is worried and wondering what they could do. So these are the way that we come about. But the next thing we do is that we try to diagnose the community, and we diagnose the community based on the stages of change following the trans-theoretical model. So we try to ask some questions around the community to see if the community is in pre-contemplation, in contemplation, in preparation, in action, or in maintenance, because that's the only time you can really start talking to that community. In the traditional African approach of storytelling, the belief was always that you must know your audience before you can tell your story. So when an African storyteller tells a story about a tortoise that is maybe cheating its friends and going to heaven on a party and then being dropped from the heaven and breaking its back, it is because they understand that a similar kind of problem is going on in the community and they want to build a story around that. Slide, please. So we develop a research question using population intervention control and outcomes. We search the relevant database. For example, a research question could be how effective is the COVID vaccine to reduce hospitalization and deaths. So we search the relevant databases, we find the evidence, we summarize it, then we develop evidence statements for storytellers to use. Slide, please. So when we have developed this evidence statement, we call together the storytellers. We sit storytellers and scientists, and then we moderate them. So they sit and they discuss and they get these evidence stories into stories that are developed by the storytellers, and then they are ready to be told to the community members. Slide, please. So this is, for example, how we believe the storytelling works. And this is from a study by Richard published in 2019, but which fits very squarely into the work that we are doing. So citizens and scientists are on one side, science and society are on the other side. And our work tries to bring them together in storytelling and to bring about behavior change in the community. Slide, please. So this is an example of an evidence, how a story is developed from evidence statements. So this is an evidence-based recommendation, which says bed nets treated with insects killing chemicals reduce child deaths. And these are actually points that are echoed in a systematic review from Cochrane Library, which is also in the WHO guideline for treatment of malaria, and which has been ratified by the Ministry of Health in Cameroon. So we break this down from the complex scientific language, because the complex scientific language will talk about insecticide-treated bed nets, where we call these bed nets treated with insect-killing chemicals. We leave a particular message for the artist. We say, storytellers communicate importance of sleeping under bed nets with emphasis on the fact that deaths are likely to occur if babies don't sleep under bed nets. So there is also a remark as to where we got the study. For example, the Cochrane Review is Price 2018. Slide, please. So this is, for example, what you see. This is the research evidence that comes from the publication that has been published, which was used by WHO in their guidelines. And this is the story that has been developed by the storyteller. So the name of the story is The Big-Bellied Frenemies. This was developed by Le Nomade. And it talks of two big-bellied friends who are also enemies. One of the big-bellied friends is a pregnant woman, and the other big-bellied friend is the mosquito that has sucked the blood. So both of them are actually, they can actually buzz in the ear of the man who is recounting this story. So he says his wife is always on his ear, that she needs this to go to the clinic, she needs that to go to the clinic. The same thing as the mosquito is also buzzing in their ear. So this is an example of a short story that was written to communicate to people the importance of sleeping under mosquito bed nets. And in one instance, in the first verse, the character there doesn't sleep under the mosquito bed net and is always cursing his pregnant wife and the pregnant mosquito. Meanwhile, the second character is always cherishing his pregnant wife and also putting her under a mosquito bed net. So in the end, he has a good baby, a healthy baby who is of good weight. Slide, please. So the main challenges we have had is the evidence hesitancy, the lack of funding, and our ability to analyze existing data. And then also there's always a challenge in the scientist-storyteller relationship. We keep going back and forth, trying to negotiate. Why does the artist think that this is how we should have it? Why does the scientist think that this is how we should have it? Why does the storyteller think that we should have this under the tree at moonlight, and the scientist thinks that we should have this in the town hall? These are some of the kind of challenges we try to negotiate in the relationships between the scientist and the storyteller. Slide, please. So the perspectives on this, in 2021 has been the most promising year. For example, the WHO has just asked us to come up and present at this webinar, which is very exciting. And as we've told WHO before, this is exactly what motivates us. The Ambassade de France au Cameroon has also supported us to develop some components of storytelling, especially for sexual and gender-based violence. Meanwhile, the Education Foundation is looking at developing key information for teaching and learning for citizens to be able to make informed choices as to which kind of stuff, as per their decision to go to school or not to go to school, to do homeworks or not to do homeworks. The same with the scheduled program. And we've also just been selected for a Grand Challenge Canada award, which we are still looking forward to concretizing and negotiating everything with them for sexual and gender-based violence. We have also had some interest from the World Bank for storytelling around allowing, encouraging kids to go back to school after conflict in the Northwest and Southwest of Cameroon. And all of this have been happening in 2021. So 2021 is a good year for us. So more research on community diagnosis using trans-theoretical method. This is where we are really looking for a way to really further develop. And we actually believe that less than $100,000 worth of research grants can actually help us to further study how the trans-theoretical model actually fits into the storytelling or the traditional storytelling approach that has always been in Africa. And this will make very interesting meeting between African cultural approaches and modern science. Then another perspective is integration and systematization. We are gradually engaging community health workers and training them to be storytellers. And then storytelling research results as part of manuscripts in editorials. This is something we believe that could form part of the institutionalization that the WHO is actually pushing forward for evidence-based decision-making. Because if we insist that journals should have a short story of practical life that actually tells the reader how this can apply in real life scenario, then this could really institute a practice of evidence-based decision-making for citizens. And then we also want to focus on COVID-19 because it's a huge problem. Slide, please. So again, as I said, you can believe with me that we need to really take up storytelling. Slide, please. Thank you, and I share kola nuts with you. It's a common practice we do during storytelling. We share kola nuts because it's a sign of love, sharing, and wisdom. So thank you very much for your kind attention.
Thank you so much, Patrick, for this really most interesting presentation. And I think what both initiatives show very, very well is how big the gap actually is between the research and the recommendations that we develop and that we produce, and then how much extra work it really takes for this research to come to the people and to reach those that need to implement them and will benefit from them in the end. So I'm very happy that we had those two presentations by Rinja and Patrick, and we're now moving on to some of the questions that we received through our audience. And the first one comes from Kaya, and it actually asks Rinja how the COVID-19 pandemic impacted the activities of the sensitization effort. So for example, mass gatherings were banned. There was the stay-at-home order. So what kind of effect did this have on your initiative? And what do you think how these activities can be adapted in future? Over to Rinja and Nadine.
Okay, thank you very much for the question. And yes, the COVID-19 pandemic had an impact to our activities, actually. During the pandemic, we were banned to do, mass sensitization. We were banned to gather people because we needed to respect this 1 meter distance between people. So yes, it had a very huge impact because we had to stop all these activities during the COVID outbreak in Madagascar. And then the only thing that we could do was the household visits, which is totally, to 1 person or to 2 persons. And then we respected the measures, that we need to respect the 1 meter distance and all of these things. But we were really totally banned to do these mass sensitizations and focus group discussions. So actually it had a very big impact to our activities. And how do we see the activities in the future? I think that if there is no COVID-19 on the field, I think we could continue our normal activities, like talking about mass sensitization or focus group discussions. But if the COVID-19 is back, or unfortunately here again, then we need to adapt again our activities according to the measure from the government of Madagascar. So that is basically, from my point of view, the future of our activities now. Thank you very much.
Thanks, Rinja. So the next question comes from Vita, and well, Vita would like to know how this singing or also the storytelling approach could be used to promote mental health issues. And I think this is a question that could go to both initiatives. So I'm kindly asking Patrick to take this one. How do you think the approach could be adapted to tackle mental health issues?
Yes, so this is also mental health issue is an interesting topic that we have been focusing on. We have something in the works for mental health, because storytelling in itself is healing. It could be used as a form of trauma healing. And we are particularly looking at conflict areas where kids have lived with a lot of violence, and also even in families where people have lost a loved one and things like that. So just telling stories could be healing in themselves. But now, storytelling in the approach that we use could also potentially be even more useful, because you get to understand the community, understand the problems where they are coming from, understand the conflict that might have existed between individuals. And you can actually use a story that will promote social cohesion while having trauma healing at the same time. So it's an approach that we are very happy to pursue, and we have actually already started doing some background work on that. Thank you.
Thank you, Patrick. We do have another question that I would like to pass on to Nadine and Rinja, and also kindly ask you to switch on your camera if possible, so that the people can see you while you're answering. So our audience is interested in learning whether your messages have been tested before you started to do the singing sensitization, And if, for example, it was ever an issue that the rhythm and, you know, people were so in the moment that maybe this entertainment element kind of overtook from the health message. Do you have any experience on that?
Yeah, I could maybe start. So, well, we did not do like kind of scientific pre-testing, but of course, every like messages that we transmit with the songs and with any sensitization activity are aligned with the national guidelines from the Ministry of Health, and we also get in touch and closely work together with community leaders. Those are called chef Fokotani in Madagascar. It's like the lowest administrative unit, the leader of the villages, and are presented to them so that they give their approval for bringing these messages the way we are doing it to the community. Yeah, and about the question for the rhythm overtaking the message, that's quite an interesting question, and I read it in the chat, and I was thinking a bit about it, and I actually I have no solution for that. And I really see the point. I'm not sure if the team on site recognized this or found this to be an issue. Maybe Winja has something to add to this, but yeah, it would be very interesting if you are the one bringing up this point, has any particular ideas on how to tackle this. Yeah. Thank you.
Hello?
Yes, we can hear you.
Yes. Talking about the rhythm, if it can overshadow the messages, I think before we start to sing, we always tell to the people that are listening to the sensitization that please listen carefully to the lyrics, because we are trying to send messages to you through the lyrics. It's not most about the rhythm, it's more about the lyrics. So we always tell the people that are listening to really focus on the lyrics. So I think that it's more about the lyrics rather than about the rhythm. The rhythm is just about, you know, to get people entertained and to catch more ears, to catch more people around so that they can come and attend the mass sensitization. So I think it does not overshadow, but it's a kind of telling the people before to really listen to the lyrics. Yes, thank you.
Thank you so much. I just learned that also Patrick can add a little bit to this discussion about the role of music in the storytelling. Patrick, over to you.
Yes, thank you. So we actually have one of our storytellers who is called Leoman. He believes that music and light should actually be used in storytelling to flow with the message. So he doesn't tell his stories without a particular rhythm. So there's a time when the rhythm goes very harsh, a time it goes gentle, a time he wants the light to be dimmed, a time he wants only the fireplace to be burning. So he has different ways, and it is really very, very effective if you sit at one of his stories and you listen to the music. So I think music rhythm is something that we can actually tame to support the communication of our message. Thank you.
Thank you. We do have another very interesting question that is relevant to both presentations, actually. So how about this uniform direction of the song and the storytelling? So we do have someone asking whether it wouldn't be more effective to have this dialogue element in the interventions to ensure that also, you know, people understand the information correctly, that there is feedback if they have questions. So maybe Nadine and Rinja and then Patrick could add on how they make sure that the message comes across in the right way and that people can also respond to what they hear.
Okay, I think I would like to talk first about that, because during our mass sensitization, we first try to sensitize, like talking, you know, sending the message to our local community, our health worker, and then we try to talk about the topics first. And then in between those messages, we put the singer in front and try to tell the same messages, but in a song way. So we are kind of mixing, the song and the message, talking about the message. So it's not only singing, but it's like following the song with a clear message, just to put, everything on its place. So yeah, it's not only singing, but to be doing two things together. Thank you.
Thank you. Maybe Nadine could add a little bit on this feedback mechanism.
Yeah, maybe I have one more different but additional thought on this. I think it really depends on the message that you are transmitting. Like you have the different techniques of communication, and I mean, if you have, at least for us, if we communicate more general messages, like why it is important to access health or to get to the health facility, applying mass sensitization or like this single sensitization strategy is maybe very appropriate, and you don't necessarily need to have this like direct dialogue. But then when you go to specific health messages, like why it is important for pregnant women to go to a hospital for a specific condition, then of course it's very essential to have to apply a sensitization strategy where you have the ability to discuss and respond to questions. So I wanted to add the thought that it's not every message which profits from the same technique. Yeah.
Thanks, Nadine. Patrick, over to you.
Yes, so on one of the slides, I had mentioned about the feedback, with the assessment and the feedback that we have. So what we do sometimes is that we collect telephone numbers. We also ask for some questions after the sessions. And normally when we ask for telephone numbers, we tell them that we will share with them the clips of the stories. So because it's interesting, they would easily share their telephone numbers with us. So we use these opportunities to ask them questions after that. After the storytelling, did you change the way you behaved towards requesting for injections, for example, those kind of questions? And that's how we're able to really understand aspects around evidence hesitancy. And this is what we have done so far. But in truth, I think that for us to be able to really understand or measure the impact of this approach, we really need to have more of that feedback, which could be through questionnaires or something of that nature. But it may be more useful to do this within an experimental setting where we would have a group that is receiving this kind of storytelling event, and then we actually evaluate how they change behavior over time. Thank you.
Thank you, Patrick. And that kind of already answered another question that we had on the impact assessment of the storytelling. So I know you mentioned on one of the slides that there has been very little to no funding for this initiative, actually. So it wasn't really possible to have a big formal evaluation yet. But if you had a champagne budget, like what would you do to measure the effects of your initiative?
So if I had a budget to measure the effect, I already understand that there's acceptability of the approach is feasible. I know exactly what dose will bring about what kind of effect. So I will now want to actually evaluate the impact on lives, on behaviors, on morbidity, on even mortality. So I would look at outcomes. There are key outcomes that we have started to understand that if we actually know that this behavior is changing, if we take COVID, for example, this number of people are going for vaccine because they listened to story. And because they took the vaccine, the hospitalizations reduced or the number of deaths reduced. This is the kind of thing we will do with this kind of funding. Thank you,
Patrick. And maybe also relevant to Nadine and Rinja. So is there any impact evaluation ongoing already? And if not, how would you think it would be most useful for you to measure the effects of your projects?
Yeah, thank you. So we up to now, we only have, like, we measure our impact by counting the beneficiaries, the people that are attending the different sessions. But of course, that doesn't really measure the impact of what we are doing. So we would love to have more operational research activities to conduct while doing our sensitization. What we would do, well, I mean, there would be plenty of activities or of things that you could do to measure the impact. But I think one thought on this would be especially to do it in an iterative way. So just collecting data on the impact, bringing it back to the design of the matter of the activity, and then it would be, of course, something continuously done. Yeah.
Thank you. We're already close to the hours, so unfortunately we don't have time for many more questions. I would just like to reiterate how grateful we are for you to present at today's webinar. And I'd also like to reemphasize again how impressed we were with your initiatives, because I understand that this has been pulled together with very little funding under huge constraints in terms of human resources, and then of course the situation due to COVID-19. But I think it's also shown very well that you could draw on previous experience. You both have been very active in these areas before the pandemic, and how much that has helped with coming together now. So before we close, I'd like to give the floor back to you for, you know, some final comments and maybe reflection on what you would need as a support for your efforts to continue to be successful in the future. Nadine, do you want to start?
There were 2 points. Yeah, thank you very much, Ramona. There were 2 points coming to my mind. So first of all, and especially as Patrick already mentioned several times, of course you need funding to do these activities. So it's yeah, I mean, not the most important, but it's just an essential factor. But this is not why we are joining in here. So I'm yeah, I would be really amazed if to get in touch with people doing similar activities in similar settings, and feel free to contact us and report on your activities and experiences, and happy to share ours also in more detail, and yeah, be in touch and learn from each other. So yeah, I'm happy to bring in our email contact in the chat. So if anyone wants to get in touch, please do so. Thank you.
Great, thank you, Nadine. Rinja, would you like to add anything?
I just want to thank everyone for listening to me and for really getting those experiences from the field. And thank you also, Nadine, for doing this together with me. And I hope that we get some improvement in our activities. And yes, thank you, everyone. And maybe see you maybe in another webinar. Thank you.
Thank you. Patrick, over to you for final remarks.
Yes, so I think I'll also echo funding and networking are key. Funding will help us really dedicate time, protect time to really study the approach. And because it's culturally appropriate, it's going to really fit into the setting. Then secondly, the networking, because we can still find people within the networks that could help us with issues around understanding the data and the results. So thank you. That's where I am.
Thank you so much. So thank you very much to our very engaging speakers for bringing and sharing your experience of these really super interesting projects with us. To everyone in the audience, thank you so much for joining us today, for being engaging, asking your questions. It was a pleasure to have you with us. As I said, we will publish a recording, so if you know anyone who could be interested in this topic, you'll be able to share a link. We will also send this out to everyone who's been registered. And then in terms of networking, WHO is planning to publish a good practice repository on science translation efforts at the end of the year, early next year. So there will be further examples that you can look into, and then also get in touch with the initiators in terms of innovative science communication. I know that doctors from Madagascar will be represented there, and we'll also be in touch with Patrick to make sure his example is included in the repository. So with this, again, thank you everyone, and we hope you'll join us next time for the 4th Science Communication WHO EPI-WIN webinar. I wish you all a wonderful rest of the day, a lovely evening, depending on where you are, and hope to see you soon. Stay healthy and safe. Bye-bye.
Thank you. Bye-bye.
Thank you very much. Bye-bye.
Thank you very much. Bye-bye.